Hey UTRGV! Welcome to my crib. This is the hospitalist office. This is Chelsey Pinto. I'm a class of 2020 alum, and let me tell you a little bit about more of my life post-grad. So now that the camera's in a more stationary place, I'm Chelsey Pinto. I'm a class of 2020 grad, and I'm originally from Southwest Michigan. And my journey to becoming a PA, I think we all kind of have a very similar starting, right? Like you're trying to decide between MD, DO, nursing, veterinary, dentistry. And so during undergrad, I was shadowing a bunch of docs, and they're all like, I hate my life, I'm so tired, I'm in so much debt, don't do it. And then one day I was with a doc, and a younger gentleman came in. He's like, hey everybody, it's a great day to see some patients, let's go. And I was like, who's that person? And the doc was like, oh, that's my PA. So I asked to shadow that guy, and he was wonderful. They still did a lot of the same things. They saw patients, and he told me about, PA school, and there's much improved work-life balance, and that's really got me started on pursuing the PA degree. I specifically targeted schools in the Southwest of the United States because I wanted to become a bilingual provider. So yo hablo español. There's a lot of Spanish speakers here in Michigan, especially in summers, due to agricultural travelers and people coming up to do crop picking. And I knew that it'd be a really good bargaining chip after graduation to be someone who works here and speaks Spanish. So that's how I ended up at UTRGV. And the beautiful weather and the excellent Tex-Mex food was certainly a huge draw too, right? So my field of medicine is I do hospitalist medicine, more specifically acute care or critical care. So what does that mean, right? And I also do rural medicine, which I'll tell you a little bit about. So anytime a patient is admitted to the ED or coming to the ED and are sick enough to be admitted up to the hospital floor, either the regular floor or the ICU, they're being admitted to me. And just, I work at night. I work by myself. So it's just me here. So if someone goes critical, if there's a code, guess who's seeing you? Me. So I work, and when I also say I work rural medicine, I mean I work for a very small hospital. My hospital has 25 beds total, and I'm responsible for all of them. If someone goes critical, if someone starts having kidney failure, if someone starts having an MI, all of them are my problems. So there is no cardiologist here, there's no nephrologist here, there's no ortho here. So guess who's doing that? Me. I do have the option of calling 24/7 to whoever's on call, because I'm here at night, but they don't always respond to you right away, and so I've had to really rely on my education, my research skills, kind of utilizing UpToDate a lot. I've been attending a lot of conferences to kind of further expand my knowledge, because a specialist may not get back to you right away. And what are you going to do? You're just going to let someone sit and suffer? No, you have to intervene. So it's kind of fun because as rural medicine at night by myself, I'm doing a little bit of everything, but I'm also covering or taking care of ICU patients. So patients on, very intense medication drips, ventilated patients, which I learned a lot about taking care of because I started right during the Delta and Omicron wave. So it's a lot of bits and pieces, but even in PA school, I was called No Chill Chelsey, and it's still the case, so I think it's a good fit. I don't know if I'd be challenged anywhere else. I think I'd probably be bored. A typical day for me is I come in right around 7 p.m. I get a report from the outgoing PA or the doc if they're still here, because during the day there's two of them. They kind of let me know who's new for the day, who's very sick, who's like pending results, who's kind of in a dangerous place and I need to keep my eye on, or what am I waiting for them. And then the rest of the night I will spend admitting new admissions from the emergency department, as well as checking on my sick patients that are already here. So if I get some results back from an MRI, I'll go talk to them. Or if a patient starts going septic and their blood pressure's in the dirt, I'll go check on them and intervene. If someone starts having a stroke, I'll get a rapid stat CT and consider starting TPA if that's appropriate. So my typical day is not very typical. It can be anything. It depends on who's here. It depends on how sick people are. It depends on what resources we have in the hospital at that time. And I will say though, with the Delta and Omicron waves having since passed, we're seeing much less numbers. I mean, there was a night where I had 28 patients on my floors, and then like 5 more in the ED, and I was responsible for all of them, which gets to be a lot to juggle, especially as a new grad, right? An interesting case that I had was during like the height of the Omicron wave. So working in rural medicine, you deal with a lot of misinformation, right? Everyone's going on Dr. Google, Dr. Facebook. There's not a lot of educational support or educational background, especially in like these underprivileged counties, which is where I work. So I've had to work on combating a lot of misinformation, especially with COVID and vaccines. So during the worst of the Omicron wave, there was a rumor, or someone had posted on Facebook, that if you go on the ventilator, we're giving up on you, you're basically dying, right? This is of course not true, but if you're sick enough to be on the ventilator, you are very sick. This is not something that we do willy-nilly, and we would try to do everything we could to avoid having to intubate somebody with COVID, just because the barotrauma is significant. Anyways, a middle-aged gentleman had heard this rumor and was refusing the vent, which of course, if someone is lucid, they are allowed to refuse the vent. I can only explain so many times why this was the best course of options, but you're allowed to refuse. So we had him on high flow for an extended period of time. High flow is kind of like a souped up nasal cannula that can go up to 40 liters per minute in nasal prongs. So obviously there's going to be some pressure there, right? Like 40 liters per minute. This gentleman had refused a lot of our appropriate interventions for COVID, remdesivir, Decadron, you'll learn all about it when you start working, and had resulted in a pneumomediastinum, so air trapped in between the lungs and behind the heart from all this pressure. So a result of barotrauma. And the attending doc who had stayed over to help me out with this, he's like, "Are you ready? We're gonna decompress." And I was like, decompress what? There's a sternum here. This is not like the needle decompression here for a pneumothorax. This is a pneumomediastinum. So thankfully, the doc handled that with some ultrasound guidance, but it was definitely really an interesting procedure to get to be a part of, and patient didn't end up doing quite so well, but it was a really great learning opportunity to see just the effects of long-term high flow, which we would have patients on high flow for weeks at a time. So it's not always better than going on the vent. Something worth thinking about. I have a lot of like COVID stories. That's the ICU, man. I think everyone's gonna like this question of Professor Gonzalez the most. What's your first purchase? Right? We all everyone's like, "Oh, I'm gonna get this, I'm gonna get that." So my first purchase, I did a couple things. I bought a Nintendo Switch. I wanted something just for the joy of it. Now that I have not all, but I had more free time than I had had in a long time. I really wanted to play the new Pokemon Snap game and the new Mario Kart. So that was my big purchase. And then I took my husband and myself out for a really nice steak dinner, and then I bought my mom a dishwasher. That's really what I wanted to do. And since then, I've taken a lot of really big steps to pay down debt that I accrued in PA school, and I got a new car. But the first big ones were the Nintendo Switch and the dishwasher. The most gratifying thing working in ICU as a hospitalist is when a patient leaves AMA. I'm just kidding. It's not true. Actually, the most gratifying thing is when you're seeing someone genuinely get better. They come in incredibly ill, they're admitted to ICU, they're on tons of fluids, they're on blood pressure support, they're on ventilation support, and you always have to have this kind of thought in the back of your head of, this may not go where we want it to go. In fact, when I first started this job, I was terrified. I remember speaking to my attending physician, and I was like, what if somebody dies? Like, what am I supposed to do? Even after all this effort, what if someone dies, right? Because the risk of someone passing in your family care practice is quite low, right? The risk of a small child dying during your pediatric visit is very low, right? The risk of someone dying while they're in the ICU is quite high, and that's a real risk that you have to mitigate taking care of these people. So I talked to my attending physician about it, and he was like, Chelsey, people die in the ICU. This is what happens. It's, you can try your best and still fail. And he's like, I'm not gonna yell at you and fire you if you're still trying to do your best. And so obviously, like, it's still a stressful situation, but it made things a little less terrifying because it's not expected, but it's not outlandish either for someone just to be so ill or so beyond what I can do, what we can do at the hospital to get them to a stable, improved place. So that said, when someone does improve, and I come see them after I work nights for 12 hours, I come see them the next night and they're talking, or they're off the vent, or, they're requiring less pressor support and they're able to be like, I remember you. It's the best feeling in the world. The other best feeling in the world is, since I'm doing rural medicine, right, and I don't always have access to specialists, I have to go with my gut sometimes. I have to go with the education that I received, that I worked so hard to maintain. And so the other best feeling is I have to do an intervention and wait for the consulting neurologist, nephrologist, cardiologist, someone smarter and far more talented than I am, to review what I have done. And the second best feeling, aside from someone actually getting better, is for this genius person to be like, that's what I would have done. Good job. Way to hold it down. Man, put that in a bottle. That's good. So my biggest piece of advice for both didactic, clinical year, and capstone students, it's all the same, is you need to get sleep. Even when I was in PA school, I was like the biggest proponent of getting good sleep. Even now, working nights, I'm still a huge sleep hygiene person. Everyone knows my phone is on silent during the day because I'm asleep. And during PA school, I was like, don't call grandma after 10:30. I'm not going to answer my phone. I'm in bed. Sleep medicine is a big passion of mine. I took a couple classes in it in undergrad, and studies have shown the student who stays up all night studying does worse than the student who called it a night at a reasonable hour and got a solid amount of sleep. During PA school, you're stressed, you're missing your family, you're freaked out, you're working your butt off, you're getting pimped by preceptors. All of these, are just so much more challenging to emotionally regulate if you're not getting enough sleep. If you're not able to kind of take care of yourself in the best way you possibly could under all these circumstances, how are you possibly going to be able to cope? You're going to get sick, you're not going to be able to remember as well, you're going to just be doing real rough. So my best piece of advice, and I know it's hard to take, but I challenge you to try to give yourself an extra hour of sleep, just to see the improvement of your recall, of your attitude, of your just overall positive feelings of the day. With a little bit extra sleep will tremendously improve everything, honestly. Go to sleep. Get some good sleep. Okay. Have fun at PA school. Make friends. You're gonna miss it. I miss it. Not the work, but I miss seeing my friends every day. Good luck, guys. You can do it.